neurosurgery, neuroscience, to neuropuncture, and to rehab. And now we're going to go to pharmacy. And we're very excited to have Xiaodong Feng with us. And because I'm married to a man with the same name, I know his name is actually Feng Xiaodong, but we'll call him Dr. Feng too. Or maybe he's one of your two. I don't know. We'll figure that out. But he's really an expert in the area in which he's going to talk with us about. You can see from his bio that he's quite accomplished with both a PhD and his doctorate in pharmacy, and he's currently with California North State University, where he is the Dean of Pharmacy. He's going to speak to us about the new vaccine for glioblastoma. Thank you, Dr. Feng. Yes, and it's just that button down.
Okay, all right, thank you. Okay. Good afternoon, everyone. Great honor to be here. So especially as a Chinese, when I say the opportunity to integrate Chinese medicine, acupuncture with Western medicine, it's just, thrilling, like basically have the opportunity to be associated with such wonderful group. And a special respect to Dr. Amy Mataki, for pioneering this effort. And I feel like that's a goal of patient care. It's not about, this is modern medicine, this is a traditional medicine. It's about what's working for our patient, what's helping our patient. So today, it's my honor to have this opportunity to be here, talk about a new topic about cancer vaccine. And we're going to focus on glioblastoma. All right, so this actually lecture is more focused on the education. So its sole purpose is for education and not intended for any kind of commercial promotion. And I don't have any disclosure for financial conflict. Okay, this is the learning objective. So basically we're going to, sorry, I'm getting old, barely can see the screen. All right, so we're going to, I think, let's see, can we make it bigger?
You can take the mic off and walk.
Okay, that's better. All right, so we have 5 learning objectives. So first, we're going to talk about glioblastoma, GBM. So what is the standard of care and what's available for the treatment, including some new investigational treatment, particularly about immunotherapy. And the second, we're going to explain the role of stem cell. This is getting exciting. When we talk about cancer, many times we just talk about chemotherapy, targeted therapy, immunotherapy, barely touch on the cancer stem cell. Actually, this is the reason why cancer is so hard to treat, why it's constantly coming back. So we're going to talk about its role in resistance, recurrence, and immune evasion in glioblastoma. Next, we're going to compare the mechanisms of action and how to deliver the current and emergent GBM immunotherapy, and then followed by evaluating the preclinical evidence supporting the efficacy of cancer stem cell-based GBM vaccine. Unfortunately, now, all the study is preclinical. It's so advanced. However, immune invasion is coming very soon for clinical study, yeah. So, but anyway, so far, based on the animal study, it's amazing. It's just, cannot wait to see it's put into clinical trial. So last, we're going to talk about the translational advantage and the clinical implementation of this cancer stem cell-based vaccine. I can tell you, if it's working for GBM, pretty much it will work for most solid tumors, yeah. All right, GBM, actually, this is a very old name. It's a glioblastoma multiforme because of its heterogeneity, and also look at the pathology, morphology. It's just so diverse and with multiforme. But now it's kind of a traditional name. However, people still like to call it GBM. Yeah. So this is one of the most common brain tumor, and accounts for like about 30% of the brain tumor. However, it's the most malignant brain tumor, accounts for 80% of the malignant brain tumor. That's scary, 80% we're talking about. So around like 100,000 patients, you will see about, 1 to 4 patients with GBM. It's very common with non-Hispanic white patients. And also it's less common in Asian and Pacific Islanders. So this is just some demographic data. And also, unfortunately, it's more common in men. I think for men, we have like about 1.5. Okay, all right. So we're going to have more risk than women. So it's about 1.5 to 1 ratio. All right, so for oncology, we know recently there are like so many revolutionary treatments for cancer, such as breast cancer, lung cancer, colorectal cancer, even for, melanoma, particularly with immunotherapy. But somehow it's not working very well with GBM. And, before the afternoon session, I had a conversation with Dr. Mataki and talk about, some of the cases she was treating. We start to see some progress, but it provided opportunity for us to integrate the bench work with the bedside patient care and to start to look into, what is the true reason why GBM is so hard to treat. And particularly look at here, now GBM, so basically the overall survival, it's kind of still around 15 months. And after the standard treatment, which is surgery, radiation therapy, and chemotherapy, and the 5-year survival is less than 5%. So it's disappointing, right? So that's why we want to explore some new opportunity. When we talk about vaccine, it's not only prevention, also vaccine can be used for the treatment. So that will be focus for today's discussion. So, and also it's scary without, treatment. So the median survival is just 3 months for GBM. So that's why we have no choice. We need to put all the effort to explore the possibility for treatment. And, GBM generally, when we talk about the standard treatment protocol, so it divided by the, new GBM or recurring GBM, because the treatment strategy will be different. And right now, the recurring GBM, there's no real standard therapy. It's more like trial. This slide is a little bit busy, but it's more like a give an overview. What are the available standard therapy for the treatment? And the surgery, based on the diagnostic technology, we try to be as precise as possible. At the same time, try to integrate with radiotherapy or combine with target therapy or even angiogenesis therapy. But so far, the outcome is not very good. So for example, now chemotherapy, we start with temolizumab. It's basically a chemotherapy. TMZ is alkylating agents. We know alkylating agents is very, very toxic, and also, with a lot of side effect. Basically, based on the earlier introduction, we see the opportunity to integrate with the acupuncture, with the herbal medicine, even with the acupressure, such as chemo-induced nausea vomiting, especially for the anticipatory chemo-induced nausea vomiting, and some of the toxicities such as neuropathy, and the pain associated with the fever and fatigue. There are many, many opportunities, so later we will talk about this. But here it's just, if purely based on the TMZ, the new generation of targeted therapy, targeted therapy combined with radiation therapy, and even like later with recurring, you do surgery again, it's just not showing the promising outcome. So we definitely need to put more effort. One of the reasons is GBM. It's just even now we still don't know what's the reason causing GBM. People say it's genetic. People say, oh, it's could be secondary. And right now there are some new paper published in Nature and even talk about virus-induced GBM, especially caused by CMV. I don't know, like many of you actually even saw that paper. They start to do some kind of trial to try to treat GBM patients with antiviral drug. So anyway, it's exciting. There are many, many options we can look into. All right, so here just kind of quickly talk about available treatments. We call it standard of therapy, such as temozolomide. As I mentioned, TMZ is the most common adjuvant chemotherapy given together with after surgery or radiation therapy. And the combustin is a new agent. People start to try it, and because it can cross the blood-brain barrier. And bevacizumab is the first FDA-approved anti-angiogenesis therapy. Do you guys know what is the angiogenesis? It's a new blood vessel growth. And the concept is basically for solid tumor, in order to survive, to grow, to spread, you want to, and that's one thing I always feel amazed. Cancer cells, they're the most smart cell biologists. They know everything, try to get through and try to survive. So basically, they stimulate the production of VEGF, which is the vascular endothelial growth factor, to stimulate blood vessel to provide the nutrition and the oxygen. And this is one of the features for GBM is like in the center of the tumor, you see severe necrosis because of the hypoxia. But that also make it so difficult to treat because when the blood circulation cannot get through, doesn't matter how strong is your chemotherapy, and in the center you still have the tumor there, especially the cancer stem cells. Yeah. All right, so, but anyway, bevacizumab is the new generation of angiogenesis therapy. Right now got a lot of attention. So it's indicated pretty much for all the solid tumor, including breast cancer. But for breast cancer patients, because of the toxicity is more than the benefit, so FDA actually revoked the indication for breast cancer. But so far it's still indicated for lung cancer, like ovarian cancer, most of the solid tumors. So we will see, so far actually it's still kind of as adjuvant therapy, like basically together with the surgery radiation for GBM treatment after they failed the TMZ. Tyrosine kinase inhibitor, and we know GBM is kind of epithelial, brain tumor, and so that's why they, the EGFR target therapy based on the tyrosine kinase inhibitor, such as the gefitinib, alatinib, provide some potential opportunity also for the treatment. Of course, they also have some new technology, use the thermal ablation, or use the electrical field, it's exciting, but so far it's all at the early stage. So right now, the biggest challenge is, when we talk about cancer treatment, the outcome, generally, if you can improve about 2 or 3 months, that's already amazing. However, based on the potential of cancer vaccine, we start to see people's, overall survival rate actually could be doubled even. So now let's quickly talk about why, we mentioned earlier, with the emerging immunotherapy, many solid tumors, we start to see the potential become a chronic disease because of the immunotherapy. However, for GBM, somehow it's not very responsive. And, we start to look into it. It's because of the GBM, the tumor cells, it's just so smart. And right now you can see for this year, Nobel Prize is given to a group of scientists. They did pioneer work about the regulatory T cells. It's like GBM cells, tumor cells. They're so smart. They basically modulate the regular T cells to kind of suppress the immune system. And they also modify the tumor microenvironment to make sure they're like at extremely low kind of immune environment. So that's something called a cold tumor. It's just like even you try to use the PD-1 or CTLA-4 immunotherapy, you try to remove the break, intrinsic checkpoint, immunocheckpoint break. Still, you don't have all this, almost you have the most powerful weapon, but you don't have the bullet. It's not working. So that's why one of the strategy for immunotherapy is to activate, to supply with all the, reacting immune cells, such as the T cells, B cells, to make them hot. Then make them sexy. And then, we can start with the immunotherapy. All right? So radiation therapy, generally people feel like, we cut as much as we can. But even with today's most powerful technology, with MRI, with whatever AI help, still, there are many tumors you cannot detect. So that's why surgery is just reduce the tumor cell count. And even chemotherapy, we know chemotherapy can never kill the last tumor cells. It only kills the percentage of the tumor cells. And so, in our body, the best way to get rid of the last tumor is our immune system. So that's our focus. And also there's a limitation of the current standard care, like surgery, and we already talked about, and the radiation therapy, particularly, it can even, like a trigger, activate the cancer stem cell. And also they upregulate PD-L1 expression on tumor cells. So we heard about so many commercials about, all the PD-1, PD-L1 immunotherapy, like Keytruda. I'm not promoting that drug, okay? I just tell you, how the drug is working. It's basically the tumor cells, they are so smart. I feel like they deserve Nobel Prize. Because all the Nobel Prize so far for the past couple of years, they're already using it to get through, the treatment. So basically for immunotherapy, they overproduce the PD-L1, which is the intrinsic brake, almost a brake to step on to suppress your body's immune system. So it's just almost ignoring the tumor cells, can never identify or destroy the tumor cells. And also now, they also have this regulatory T cells, the body tumor cells, they can also do it. They figure out everything they can to evade the immune system. To make it even worse, because of the cancer stem cells, not only they can, renew themselves, they also can differentiate and generate a new clone, new population of the cancer cells. So that's making it so hard to treat because of the heterogeneity and also because of the, the immune suppressive cancer macroenvironment. So even with the current immunotherapy, with the PD-1, PD-L1, and the CTLA-4, it's just not working very well. All right, so the limitation for chemotherapy, we already know all the resistance, and particularly with the blood-brain barrier, even TMZ, they can somehow, some of the dose can cross over. It's just not as efficient as a regular, systematic treatment for other non-brain tumor. So immunotherapy, we already talked about. This actually, people feel like it's the silver bullet for cancer treatments, but for GBM, because it's cold and also because of the presence of the blood-brain barrier, and make it very, very hard to treat. So now we try to look at some other way. Can we basically, instead of focusing on one tumor marker, we focus on array of the tumor marker. And also because of the cancer stem cells, they are like the kind of engine for recurrence of the tumor. Can we target at the cancer stem cells instead of just the regular, cancer cells? All right, so with GBM, it's just like the tumor itself with so many severe signs and symptoms, but particularly when you start all this standard therapy, there are a lot of toxicity, as I mentioned earlier, like fever, fatigue, and chemo-induced nausea, vomiting, and seizure associated with disease and treatment, and headache. And also VTE, I think here provide tremendous opportunity for us to integrate with, acupuncture, with herbal medicine, with acupressure treatment. So especially, we know for GBM associated with cognition, I'm sure with acupuncture, it will definitely provide a lot of positive, supporting evidence, to improve the outcome. I know, for chemo-induced nausea, vomiting, definitely acupuncture has tremendous, benefits, and also pain associated with cancer, with the treatment and with neuropathy. I just feel like this is the opportunity we can look into it. But I'm not very familiar with acupuncture and alternative medicine. Based on a lot of literature, I saw even for immunotherapy, basically you can use acupuncture or some kind of traditional herbal medicine to stimulate the immune system. And that will provide the opportunity to enhance the benefits of traditional immunotherapy, such as Keytruda. All right, so, the immunotherapy, when we talk about it, is basically two major directions. You can do the passive immunotherapy or active immunotherapy. So the passive is basically you give the immune cells, or you give the whatever, like cytokines, and to basically to attack the tumor cells. The active immunotherapy is more like let's give the vaccine to trigger your body's immune reaction to detect the tumor, to attack the tumor. So some of the treatment you guys heard about recently pretty popular is the CAR T treatment. Is basically chimeric antigen receptor T cell treatment, and also they have the CAR NK natural killer cells. Basically you can modify, genetically modify the, a receptor and infuse back. This is more like autologous treatment. You collect the patient's T cells and natural killer cells, and then you modify genetically, and then infuse back and trigger the immune reaction to treat patients. So the active one is more like the focus of today's talk, is basically the vaccine. There are many types of vaccine. So you have the peptide-based vaccine based on the tumor-associated marker. And you also have the cell-based vaccine, could be the dendritic cells or T cells, whatever you modify and you infuse back. And now you also have the virus and bacteria-based vaccine. As later we will say, the oncolytic virus. So they are like genetically modified, but they can trigger the immune reaction. And then you have the cancer stem cell-based vaccine. So the dendritic vaccine so far, they have many successful clinical trials. I think what I want to share is one concept. Instead of, the function of dendritic cell is to present the antigen. So what they do is instead of present one specific tumor antigen, they start to present with an array of the tumor antigen by break down the tumor cells and expose them with dendritic cells. So in this way, there will be many tumor antigens presented and then infused back to treat patient. So this clinical trial is a phase 3 clinical trial recently published in JAMA, Oncology. And I just want to quickly show the outcome. So basically, the treatment group with the dendritic cell vaccine, actually the median overall survival, it increased from compared to control 16 months to 19 months. And the overall survival, actually, I think for the vaccine treatment group is almost 30 months. So this is basically, the other one, first one is for newly diagnosed glioblastoma. This is a study with a recurrent glioblastoma. Generally, it's more difficult to treat, but still we see the outcome is much better. The median overall survival is 13.2 months compared to control 7.8 months. So I think based on the clinical trial data, I feel like this vaccine will be approved by FDA very soon. So far, I believe it has been approved by UK as a kind of something called a new innovative discovery drug status. So basically, for GBM in UK, you can start to use this vaccine. But FDA actually right now is going through the process. All right, so however, it comes with a cost. Basically through one course of treatment cost almost over $250,000. Okay, next I want to say the oncolytic virus. So you guys know the herpes virus or poliovirus or measles. So those actually, once we use the genetic engineering technology, we can modify it, and now it's not harming our normal cells. However, it can specifically identify tumor cells, attack the tumor cells, proliferate in tumor cells, and lysis the tumor cells. So that's a kind of a principle behind oncolytic virus. So there's some clinical trials so far going on. G207 is a herpes virus. Basically, right now, I think already phase 2 clinical trial. Showing very, very good result. So what they do is basically they generate something called DANP. It's kind of a dangerous signal in the cell to trigger immune reaction. But the challenge for oncolytic virus is our body's immune system can try to destroy them. And the survival oncolytic virus, it depends on the technology, and it's hard to predict. And even they survive, they might cause something called a cytokine storm because it's working through trigger immune reaction. But when the immune reaction is too strong, what do you expect? It will be overproduction of the cytokine and then trigger cytokine storm. So this is just a kind of flow, like how oncolytic virus is working. Is basically it can specifically infect the tumor cells. They're not going to infect normal cells. And then in the tumor cells, they're going to proliferate and cause the tumor cell lysis. And it's interesting, like basically, not only that it lyses the tumor cells, it releases all the potential tumor antigen and then trigger all the immune reaction. So you can see it has two functions. Not only itself, it destroys the tumor cells, it also releases all the potential tumor antigen. Here you see it's not monoclonal, it's multiple. It could be polyclonal. So this one actually has a huge potential as a cancer vaccine for the treatment of GBM. All right, so to make it even better, and this virus actually we can do through the genetic engineering, insert the immune modulator, such as the interleukin-2, interleukin-12, whatever you name it, and even PD-1, PD-L1 monoclonal antibody in this virus to express the immune modulators, and now the immune modulator can work together with the virus. So now you see you almost have the kind of, like a synergy, like basically to enhance the immune reaction. All right, so here is just some examples of the, GBM clinical trials based on the oncolytic virus, vaccine. So I want to highlight the major one. Oops, sorry. The major one, G47 Delta. So this one so far, in Japan, they finished the phase 2 clinical trial. However, the outcome is so promising, they terminated the clinical trial even early, and Japan actually so far approved it. But FDA, we're always cautious, or we're always behind, okay? So this is just the clinical trial published in Nature Medicine. I don't have time to go over all the details. However, the outcome is very, very exciting. All right, now let's talk about cancer stem cells. So cancer stem cell, so these are the major reasons why cancer, they have the treatment resistance, why you have the recurrence, because the cancer stem cell is a kind of cell, they can renew themselves, but they can also initiate the new tumor. So that just make it like so hard to treat. It's basically, it hides in the center of the tumor, and when it's time with the right tumor microenvironment, they start to generate more cancer stem cells, and then they can also initiate a new tumor, and they also can mutate and generate a different group or different clones of the tumor. So that's why GBM, you have the multiforme, you have different, it's just a heterogeneous tumor. They're all from different resources. So just make the treatment very difficult. If you have a vaccine only targeted one antigen, and pretty soon, like after 1 or 2 rounds of treatment, it's gone, So, and also for cancer stem cells, it's basically our vision. So we recently submitted a patent. Is a kind of not only just we focus on cancer stem cell. Remember, cancer stem cell is also cancer cell. Oncolytic virus can infect cancer stem cells. we also can express the immune modulators in oncolytic virus. So that's a term I created called the triple killer cancer vaccine. It's basically with the cancer stem cells, with the oncolytic virus, and oncolytic virus express interleukin-12. So that just makes the immune reaction very, very strong. So far, later I will show you the preclinical data. So here, just quickly tell you the cancer stem cell feature is basically it can do the self-renew, it can cause tumor initiation, and then, like it has all the biomarkers, so make it possible for us to use the flow cytometry to isolate, like specific cancer stem cells. My vision is right now it could be a good business opportunity. When we see the tumor, freeze the tumor, identify the, or collect the cancer stem cells, bank them, and then later you can, with the evolving technology, it will provide tremendous opportunity for the treatment and even for, some novel medicine, yeah. All right, so it's basically here just a further explanation, like a cancer stem cell actually, in regular tumor is about 0.1%, but in glioblastoma, based on the marker, it could be from like a 5% to 10%. Some marker actually show it could go up to 50%. So that means cancer stem cell play a very major role in glioblastoma, in GBM. Like I explained, you can basically express a lot of the immune modulators in oncolytic virus and then infect cancer stem cells and then use the triple killer to do the treatment. So cancer stem cell, like basically without cancer stem cell, like the cold tumor environment, make it very difficult to treat. But with the cancer stem cells, it has all the different existing cancer vaccine, cancer antigen, but also with so many potential, we never maybe even know, potential antigen trigger tumor and cause the resistance, cause the recurrence. But when you have like the cancer stem cell itself as a vaccine, it just provides all the potential for future treatment. So the cell-based vaccine, so we talk about some other ones like the dendritic cells, CAR T treatment. So far, I know for prostate cancer, there's one drug, it's a cell-based, it's dendritic cell-based Simplucel approved by FDA, but it's so expensive and not working very well. Like I said, it's only targeted one specific antigen. You can imagine, just the outcome not very good. So we try to look into use the cancer vaccine, using the cancer stem cell-based cancer vaccine to explore the treatment opportunity for GBM. So this slide basically summarizes so far the available cancer vaccine. The peptide vaccine is based on one specific cancer antigen, such as for GBM, EGF, R8, and also, there are some other vaccine like IDH1 so far is in clinical trial. But you also have the DNA RNA-based vaccine. So I think with the COVID vaccine, success story, so now there are many cancer vaccine based on mRNA, but also there are some vaccine based on DNA. Oncolytic virus vaccine-based vaccine we already talked about, and then you have the cell-based vaccine based on T cell, dendritic cell, and now cancer stem cell. All right, so we talk about the rationale behind the cancer stem cell. It's just like, it overcomes all the potential challenge associated with the traditional immunotherapy, but also it has its own challenge. one thing I want to point out, cancer stem cell, why it's good for glioblastoma, it can cross the blood-brain barrier. So that just provide a tremendous advantage and, for the treatment of GBM. So far when we talk about vaccine, we said, oh, it's safe, it has less toxicity. But so far, cancer stem cell-based vaccine, we don't have the clinical trial. It's all preclinical study. So this will be something we really want to focus on, especially we're expecting, like the triple killer vaccine I mentioned, potentially trigger significant immune reaction. The risk of cytokine storm should be pretty high. All right, so here is just talk about some of the markers actually we use for cancer stem cells and what kind of stem cell, like biomarkers actually we might say, if we use the traditional vaccine, you might never have chance, but because of cancer stem cells, you have like a huge array of the new stemness-related antigen, which actually can prevent, resistance and also prevent the, like a recurrence of the cancer. All right, so let me show you some of the data right now. Advantage we already talked about, and so now let's just show you some of the clinical data right now we have based on the cancer stem cells. So this is with mice, and with the model you can see we gave the vaccine 21 days before we challenged the animal with the cancer stem cell tumor. And then we challenge again at 14 days. You can see this is the control. All the mice die at 40 days. But with the cancer stem cell vaccine, they survive as long as we keep them. Yeah. Then we try to confirm, and we use another model. It also worked. Then the question is, how about just a regular GBM cell, tumor cells, instead of cancer vaccine? And now you can see just a regular tumor as a vaccine, they're not working very well. It still has some effect, but just not as well as the cancer stem cell vaccine. And then we try to identify, okay, is this really working? Did it really reduce the cancer stem cells? And you can see after the treatment, the cancer stem cell number significantly reduced. So we try to identify what's the mechanism behind it, and we basically blocked the CD4 positive T cells, or CD8. It turned out it's related to CD4. Once you block CD4, the cancer stem cell vaccine totally lost the effect. Almost done, yeah. All right, so now let's just quickly talk about the toxicity. So we already talked about chemotherapy. It has all the major toxicity, especially chemo-induced nausea, vomiting, and also bone marrow suppression. And this one, I feel like traditional Chinese herbal medicine has a significant benefit because many years ago, I have a cancer patient with significant neutropenia and tried something called Zenbaitang, and the white count just shoot up, and the patient didn't even need to give the Neupogen or Neulasta. So has a huge, huge potential. All right, and also we mentioned Avastin. This is the angiogenesis therapy with a huge benefit, but with a lot of black box warning, especially delayed wound healing. You need to advise patient to hold the medication if even they do a dental surgery, okay? Because otherwise the bleeding cannot stop. All right, cytokine storm, we mentioned this is something commonly, not commonly, can be very risky for vaccine, cancer vaccine, for immunotherapy, especially you are expecting it's triggering strong immune reaction. So it can cause fever, can cause all the cytokine released, like even like a respiratory distress syndrome and organ failure, multi-organ failure. So this is the oncology emergency. And the treatment, it's just the treatment way to control the inflammation and, try to, revive the organ function. All right, so in conclusion, I want to say GBM has a future, and definitely cancer stem cell-based therapy will provide some potential revolutionary strategy, to increase the survival rate and decrease the toxicity. But if it's working for GBM, it might also provide, future for all solid tumor treatment to make the cancer chronic disease. Thank you so much. There's the reference. And I want to say thank you to Dr. Mataki for inviting me to this amazing, exciting seminar. And I want to say thank you to Dr. Catherine Yan and our president, Alvin Chang, for supporting the cancer research at CNU. And definitely, Joanna, you're amazing, pushing me to, on track. Yeah, I have been teaching all these days. Yesterday, finished my class review for the students at 10 p.m. So I'm glad today I didn't get lost. Thank you, everyone.
Thank you, Dr. Feng. Let me give you a certificate, please.
Thank you.
Thank you very much. I so appreciate it. It was a great lecture.